lot of times when we go through an IVF cycle, we end up with a surprise called unexpected poor response. And in this talk, I would like to share some of the experiences so that most of us can avoid that situation by following certain precautions, which I am going to outline next. The first thing is we should have a clarity what we want, because the scientific leaders of our society around the world have put on different statements as follows. Some say more oocytes the better, some say normal, that is 8 to 15 oocytes is the best, others say we need eggs, not all the eggs, and then we have data saying 100 eggs will give 6.5 babies. So, we at the receiving end are a lot of times confused what is ideal stimulation, and each has to define their own ideal stimulation in their given setup and in the given situation and in their given background information, be it minimal stimulation, maximal stimulation or optimal stimulation. That is a call each has to take individually. The second area is, lot of times we confuse between a hyporesponder and a poor responder. Unless we have clarity between these two situations, most of our stimulation protocols will not go properly. If we are dealing with a poor responder patient, whatever we do, we are not going to increase the number. But when we are dealing with a hyporesponder patient, there are ways and means to avoid that hyporesponse, both during that cycle and in the subsequent cycle. When we say unexpected poor response in a good responder, all of us are speaking the topic of a hyperresponder, not the poor responder. In other words, in the current world of Poseidon classification, is the Poseidon 1 and 2 which are the hyperresponders, and the Poseidon 3 and 4 more come closely to the poorer responder group. We should have clarity on that. The second area is we should have lot of clarity in the phonetic nomenclature, follicle output ratio, follicle to oocyte pickup ratio or FOI, and ovarian sensitive index. What we are speaking in this situation is, we have a follicle output index where you have x number of follicles, and when you pick them up, you should get the x number of stimulation. One of the things we follow is, in each of the protocol, when we do a stimulation, we write what is the anticipated number of x we are going to get, and this was a powerful learning experience for us, because in the beginning we had lot of hard knocks of we writing 12 oocytes and getting 6 oocytes in the stimulation protocol. Unless we do our own key performance index or the KPI from the industry, saying that what is your KPI for your stimulation protocol and how often you are coming close to the 90th percentile of what you predicted, only then you will be able to refine and understand where we failed, and then only our stimulation protocols will improve. The other key concept is anti-Mullerian hormone and antral follicle count are the key factors that drive our practice today. Earlier they were the ovarian volume, the FSH, the stimulation tests, the previous responses, but more and more we are moving only to these parameters. But we should understand that there are still limitations in this, and these can vary. We should not anticipate an x number of follicles in a particular age. When you look at the AMH levels in this slide, where based on the age you have a nomogram, and using this nomogram, if you optimize your dosage of stimulation, you will go a long way. Similarly, when you use this nomogram of the antral follicle count and then plan your dosage, then your stimulation protocol will follow. Most of the time we read somebody saying 150 units is the optimal unit, somebody is saying 225, somebody is saying 250 units. But what we should do is we should use these scientific data charts of antral follicle count and AMH and adjust our follicles, our starting dosage based on either the AMH or the antral follicle. Then look at the follicle oocyte output index and see where we are finding our thing. Only then we can, in a very efficient way, give a good starting dosage. The other area of importance which I wanted to highlight is, sometimes we see an AMH value which is couple of months back, and then the woman has an oral contraceptive pill, and then we start the dosage based on the AMH value and then cut a sorry face that we did not get adequate number of oocytes. Similarly, a woman with type 1 diabetes has an AMH which is higher, but may not get adequate number of follicles. Similarly, in rheumatoid arthritis and SLE and in aggravated stage of Crohn's disease, and in situations where the C-reactive protein will alter your current AMH value and your follicle sensitivity index decreases. That is where the word oocyte sensitivity index is coming in. Unless we validate this information in the current cycle by cross checking our AMH value with the AFC and they are matching approximately, then we are not missing out a crucial point. We just look at the notes and think the AMH which was done a year ago is 5 or 4, and then in between the woman must have been in one of these situations, or in the recent 6 weeks to 8 weeks she is in one of these situations, and then we end up land in a situation where the follicle sensitivity index or the oocyte sensitivity index is inappropriate, and then we get inappropriate number of follicles. This is one area seldom we speak about, and seldom it is mentioned in any of the articles except as one-liners in most of the top review articles. And when you go into the references, then you find the real information, but our community has failed in in conveying the message that these are the factors which might alter our stimulation protocol. Then when we come to the possible situation of inadequate ovarian response, inadequate number of oocytes, the low follicle to oocyte index, which in a review article published by Carl Elvigi in the Frontiers of Endocrinology, this is an interesting article, understanding ovarian hyporesponse to exogenous gonadotropins in ovarian stimulation and new proposal markers, where they enlisted 5 factors as the key factors of follicle inadequate number. One is the oocyte pickup. We seldom audit our oocyte pickup. Somebody does the pickup in a larger teams, and we do not know whether the pickup went smoothly and whether the pickup timing was right compared to the HCG. The second thing is the HCG dosing. Most of the time we give the same amount of dosage based on, we never give the HCG based on the body mass index. We give HCG dosage, and sometimes what happens is you might be injecting the HCG dosage in an obese patient into the fat rather than into the subcutaneous tissue. So, your LH search may not be proper, and inappropriate luteinization can be a cause. So, the practice we follow based on an article about recombinant HCG was, if the BMI is more than 30, we make it a policy to give the HCG on the hand rather than the abdomen, because we might end up depositing the HCG into the fat tissue and the absorption profile is altered. The third is inappropriate dosage, and inappropriate asynchronous adjusting the dosage will give you different cohorts of follicles, because now it is known that in a given menstrual cycle there can be 2 or 3 cohorts of follicles developing, and if you adjust your dosage in an erratic fashion like step-up protocol, then you are stimulating an asynchronous follicle development, and then you might have different sets of follicles, but not being dominant. The next most important is low starting dosage, and the last but the main topic of this discussion will be the response due to genetic polymorphism. In this next 20 minutes, I will be basically dividing 10 minutes into low starting dosage, and we do not standardize the starting dosage. The starting dosage can vary depending on the body mass index, because obese women, the data shows they need large amount of gonadotrophins, but how often are we standardizing what dose to be given to obese women? The second is a severe pelvic inflammatory disease or the frozen pelvis. The third is the endometrioma and the endometriotic surgery. The fourth is the collagen disorders. The fifth is recurrent ovarian surgery. The sixth is using one of the parameters called AFC or AMH, and then using the age as a starting dosage. So, for our clinic we devised a rough scale parameter called optimal dosage, which is a very crude thing, but this is what we follow. Here you have the age. So, we have taken 30 years as a control. This starting dosage can be decided individually by clinic to clinic, and they based on the type of population you get it. So, if the age of the woman is 30 years, this is the starting dosage. If the age of the woman I am going to start the stimulation is 25, then I minus 25 units. If it is 20, I minus another 25. That means based on the age my starting dose is 150. Then again based on the BMI of 25, I might minus the dosage as the weight comes down, provided they are healthy, and increase the dosage as the weight increases. And I use only the AFC rather than the AMH because I am giving it in that particular cycle. If I have an AMH between 8 to 16, then my starting dose is this. If it is less than 8, then I add another 25 units. If the AFC is more than 16, I minus 25. Then I also look at high levels of thyroid antibodies, especially the antimicrosomal antibodies, and if they are very high in thousands, I add another 25 units. Then if the patient has significant psoriasis, not mild psoriasis, or long duration of collagen disorders with relapses and recurrences, and recurrence of endometriosis, that is where I think, but I never cross 300 units. I might come as low as 75 units, but never cross 300 units. Using this scale, we find it in our day-to-day practice, our risk of hyperstimulation is very, very minimal. We never cross 300 units, even though this says this values cross 350 units or 400 units, we never cross 300 units. That is one of the things we do here. And we use only one single product, the recombinant FSH, and we do not change the product. The reason is each product has its strength and weaknesses. So, in the process, when you are doing a stimulation, you have to control as many variables as possible. Then the next question is, in spite of giving adequate dose of FSH, the follicles are not growing, but you are seeing. That is where the role of LH stimulation occurs. Without giving adequate dose of FSH dosage, you add LH, you are only wasting your time. So, the key concept of a hyporesponder is you have given adequate dosage based on some of the criteria that are there in the literature. Then if the follicles are seen but they are not growing, that is when the key concept of LH comes in. So the role of LH in the last 20 years is changing. Initially it was the empirical use of LH for all older women. Then in the years between 2000 to 2012, the ongoing hyporesponder, and in the year 2016 the Poseidon concept, and now I feel the era of pharmacogenomics has come into play. So the role of LH supplementation in an ovarian response is not for poor responder, but it's only for a hyporesponder, and the concept is getting refined as follows. That is, earlier it was empirical, then they said ongoing poor responder. Then in 2016 the Poseidon group have come out with the Poseidon concept of 1, 2, which are the hyporesponders, 3 and 4 are the poor responders, and now our work is suggesting the role of pharmacogenomics. When we talk about ongoing hyporesponder, what does it mean? It says after giving adequate amount of dosage based on your BMI, age, antral follicle count or AMH, you are able to see a good number of antral follicle count, but not many coming up, and your E2 levels are lower than the desired values on day 6 or day 8, that is when you are going to give LH supplementation. And this was beautifully summarized by P.C. Wong in an article that was published in 2011, and I was lucky to part of this group where this review article has been given, and I would be willing to share this article to the group because it makes interesting reading about the concept of hyporesponder in a much better way of all the articles I have read so far. Even though I am the co-author here, the whole contribution was done by P.C. Wong and the Merck advisory group, who gave a lot of inputs when the writing was done. It's a very good article everybody should read to understand hyporesponder. So ongoing poor responder, addition of LH is with optimum dosage of FSH, low rate of follicular growth, but you are able to count the follicles in your scan, and the E2 levels are disproportionately low to the value you are getting in. That is where the ongoing hyporesponder. Then came in 2016 the Poseidon concept, because in 2011 the Bologna criteria defined poor responder but never defined the hyporesponder, and the Poseidon group felt that the initiative should be taken, which was led by Peter Humayden, that a classification and a separation of the responders based on the age and the antral follicle count or AMH and the need for LH. That is how the Poseidon concept has come in, and I will show you the concept in the next slide. So the Poseidon 1 and 2 are the upper two things, group 1 and group 2, and when you notice that group 1 and group 2 always have adequate AMH values, whereas when it comes to group 3 and group 4, they are the poor responders. So the simulation protocols for group 1 and group 2 are different, group 3 and group 4 are different. And what today we are speaking about is a group 1 patient or a group 2 patient, after we do a stimulation we did not get adequate X. That is what we are addressing today. In a hyporesponder with LH supplementation in the right patients in group 1 and group 2, you get what is there, you get what you get. That means when the number of eggs are more, you get adequate number of things, because the LH rescues the cycles. This is how that rescue happens. I will be coming forward in the next slide. The role of pharmacogenomics next come in. In 2019, we have published the paper, the role of LH polymorphism and LH supplementation in GnRH agonistic cycles, a cross-sectional study. This has helped us to understand. Till that time, we had, when we do a follicular stimulation, we had predictability issues. There are too many stimulation protocols, but what we believe is each clinic should select 1 or 2 protocols and use them judicially rather than 10 different protocols, so that you do not have a control. And the planning and quantification of your E2 levels and validating the thing, and based on that, these are the thing that is what happens till now. And using these parameters which I have discussed, which are predictors of ovarian response, which will help to do the stimulation. With the concept of the PC Wong from 2009 of Hyporesponder, we started adding LH on the day 6 or day 8 when we found the follicles were not growing at the right speed. In that context, what we did was, we felt that using LH supplementation made a difference. But subsequently in 2012, we could acquire a gene sequencer and started doing the lhcgr, FSHR thing. At that time, we were ignorant the difference between an LH gene and an LH receptor gene, and similarly we were ignorant about FSH gene and FSHR gene. But subsequently we realized that LH gene abnormalities produce inactivating mutations which produce infertility, sterility rather than infertility. Whereas when the receptor problem comes in, it is the response that makes a difference. And then we started understanding the relevance, and from 2014 we started doing it for every patient, and now we manage only by polymorphism. We have in-house sequencer. Then based on the lessons from the cross-sectional study and the subsequent longitudinal study, which we posted to all the SR members for sharing the knowledge, this is the study, and in this what happened is, the LH receptor gene has 3 major polymorphisms. Even though it has 500 polymorphisms, only 3 are important, of which 2 are significant, and we found in that 2 only exon 10 312 position change of amino at the base pairs makes a difference. That means in lhcgr exon 10 position 312, if there is a change in the base pair of A by A and A by T replaced by T, then it makes a difference. So this is what the thing. So when we analyze the instance of this polymorphism in general in the infertile population, we found 19% of the patients with lhcgr gene polymorphism at position 312, they were homozygous or wild type in 19%, then heterozygous in 45%, and 34% are homozygous. These 34% patients might end up as hyporesponders, and that is where the role of Poseidon concept is coming in, the role of pharmacogenomics is coming in, the role of LH supplementation is coming in. So the key findings in the 2019 study was LH supplementation is needed in patients with this type of polymorphism. So the conclusions of the publication was, heterozygous or homozygous for G allele are more likely to require recombinant LH supplementation. Heterozygous or homozygous for G alleles were 3.6 times and 5.81 times more likely to receive RH supplementation. This was a retrospective study, and these were the findings. We had another unique situation. Since we are doing polymorphism for everybody, some of the patients whom we did LH supplementation based on hyperresponders came back 2 to 5 years later for the second cycle, and in the second cycle we based the LH supplementation based on the genotype, and that is what the current study, which was published in May 15th, 2021. Effect of lhcgr gene polymorphism. The RS is a new nomenclature that is coming in because it is producing lot of confusion. So, in future most of the nomenclature will be based on RSW 93275 on LH supplementation protocol, a retrospective study. Here there were 193 couple with IVF cycle who had long GnRH with FSH LH supplementation, and after some years, which the gap was varying between 2 to 6 years, and in between couple of cycles outside, they came for a second cycle, and these people were categorized into one group. We had LH supplementation as per PC Wong criteria. That means LH supplementation being given from day 6, and the second group is based on the polymorphism, where there was a wild type A by A, no LH was given. If it is A by G, we gave half ampule of LH, and if we have given G by G, that is 1 ampule from day 1 supplementation, we found a huge difference, and the difference is seen as here. The light gray charts are the first cycles, the dark gray are the light gray are the cycles which had LH supplementation from day 6, and the darker gray had LH supplementation from day 1 based on the pharmacogenomics. You see a difference in the biochemical pregnancy rate, and you also see a significant difference in the delivery rates. So, in this group we also studied the whole group up to the delivery, and the conclusions are the reasons for better pregnancy and delivery is optimization of LH dose and their role in pre-implantation diagnosis. What is the molecular basis for LH need in different genotypes? So, in a 312A by A, you have an amino acid called aspirin, which at the granular cumulus cell interface, it does not impact the signaling of cyclical AMP and does not tamper with the antigen. So, in these patients there is no need for LH supplementation. When it comes to 312 G by G, the amino acid is changed to serine, and in these patients there is an impaired cellular signaling within the granular theca cells, and less cyclical AMP is produced, less antigen is produced, and here there is a need for LH supplementation. So, this is the transmembrane, this is cytoplasm, and this is where the cyclical AMP happens. So, LH acts on the cyclical AMP pathway and increases and drives the growth of follicular fluid formation and the oocyte maturity. The concept is, if you have 312A by A, that is the wild type, where the asparagine does not disturb the cyclical AMP and the antigens of the cell, there is no need for LH supplementation. If it is heterozygous, we give 37 units, and if it is 75 units, we give 1 ampule, but we never cross 75 units of LH. In the beginning years, we are given maybe for a year 150 units, but in the last 10 years, we never cross 75 units, that is 1 ampule of LH per day with adequate amount of FSH, and this has helped us to improve our pregnancy. This study has provided a strong evidence in support of supplementation of LH to women undergoing IVF based on their SMP profile of lhcgr. This stimulation regimen provides optimal level of LH supplementation needed to improve the pregnancy and the live birth. So, this is just the beginning of the pharmacogenomics, and after this we had an ad board which is based on the Merck headquarters, where they are working on a Delphi consensus about the role of FSH and LH polymorphism in current practice, and in the next 5 years we will have plenty of articles in refining this thought process. So, one might ask a question, if I do not have LH polymorphism, am I handicapped? The answer is no. If you are able to use good starting dosage and then carefully monitor the follicles and identify an ongoing hyporesponder, and if you give LH supplementation, most of the time it will help you. And the role of LH receptors is a scientific breakthrough, and with time, as the cost of those testings will come cheaper and more widely available, then I would advocate everybody to use it. Till then, my advocation is to use the concept of ongoing hyporesponder in as much situation as possible, and use genetic polymorphism in selected situations where you are in a dilemma. That is my key home message to the group. I thank you.